Hello and good morning, everybody. Thanks for those that are able to join our streams across YouTube, LinkedIn, Facebook, Twitter. We might even be on Twitter now. Our group keeps growing and growing and growing. So, welcome to our another episode of the Boston Healthcare Technology User Group. I guess I shouldn't call it an episode. Technically we're a user group. We're not a podcast. And so my name is Paul Swider. I'll sort of be the host, if you will, this morning and guide the conversation. So the mission, we're going to go through a couple of quick slides, just talk about what the Boston Healthcare Technology User Group is. And then we've got a special speaker I'm really excited to have today, Brian Smoker. We'll talk to him in just a moment. So first, a little bit about our group. The Boston Healthcare Technology User Group is based out of Boston, but we have a global reach. So I like to say we're a local group with a global reach serving a global community. And so we do this by delivering world-class speakers and learning path guidance through in-person and streamed meetups. And our mission is twofold. First, we want to bring people together and get them excited about technology and research. And then also, we have a strong focus on community and giving back and doing that through various projects. For example, one of the things we're really excited about that we've been working on this past 6 months is a Discord community with the goal of getting some of the 140 million younger people up on Discord interested in healthcare technology. So we have a lot going on for our user group. We do quite a bit. Please join our mailing list. So the URL is here. You can also get the PowerPoint slides and join the mailing list by just going to the Discord server. So if you go discord/healthcare, you'll find the PowerPoint slides from previous meetings. There's great conversation going on up there. There's a place where you can get the content, meeting announcements, all sorts of good stuff. And we're continuing to grow that out. And so now we'll jump right into why we're here today, and that is to talk about provider services. And so I'd like to start by introducing Brian Smoker and the concept, and then he's prepared a chat that he'll present to us. And so I first met Brian about 10 years ago through a mutual project we were working on in New England for a large healthcare system in New England. And it's been actually really amazing throughout the 10 years. When we first started working together, we were focused on compliance and sort of like, protecting physician time and compliance and reporting that back to the government through, what are called these cost care reports. And I'm sure Brian will talk about this a little bit more, but it started off as a fairly small effort. The idea was, let's automate this a little bit. Let's get a better handle on how our providers across these hospitals are allocating their time and spending their time. And then what we realized shortly thereafter is that the data that we were collecting was very valuable, and that it gave some really important insights into the organization as a whole that allowed them to be more effective in managing time. And so that's grown throughout the years, and now we've got this full-blown concept of provider services, and there's an entire group called provider services, and so without talking too much more about this, I'll turn it over to Brian. And so Brian, first I'd like to just thank you for being here, and see if you want to just maybe start things off by introducing yourself a little bit and giving us a quick introduction to provider services, and then I'll sort of fade out in the background and let you do your thing, if you will.
Great. Well, thanks, Paul, and thank you to you and Diana and the Boston Healthcare Technology User Group for their time. It's been great to be part of this group for quite some time now and see all the stuff that's taken place in healthcare. So always lots to do and lots to learn when you're talking about healthcare. So as an introduction to myself, as Paul said, my name is Brian Smoker. I have over a decade experience in healthcare. I've had the opportunities to work with everything from large clinics and academic medical centers to general hospitals, critical access hospitals, essentially the whole spectrum of health system. And boy, what an interesting journey the last decade and particularly even the last year has been in healthcare. I have an MBA and an MHA, which supports that work. And then I live in the White Mountains of New Hampshire with my wife. We actually have 5 kids. I often say 5 kids, 2 cats, 2 dogs, 5 chickens, a few ducks, and a partridge in a pear tree somewhere. And every once in a while through the yard wanders a moose, bear, or turkey. So lots going on, it's a fun thing.
And I've actually been up to that part of New Hampshire. That's a beautiful part of the country. For folks that have not been up to the northern part of New Hampshire, almost sort of close to where it borders Vermont, up into the White Mountains, it's called, right? Is that area? It's a beautiful, beautiful area. And my biggest memory of being up in that area was the road that goes up to, it's Mount Washington, right? There's a road that goes up. So I would encourage anybody that has an opportunity to get up to your neck of the woods. It is just stunningly beautiful, and that road is amazing. And so anyway, back to provider services, but I had to throw that out there because you do live in a beautiful part of the country.
Well, anytime's beautiful, but now that we're solidly into October at the time of this recording, it's a beautiful time of year in New England. Yeah. So, yes, as Paul mentioned, the topic for today is provider services and really how that impacts the provider experiences in a healthcare system. So imagine this for a second. Imagine I went down to Boston. It's down for me to go down to Boston. I go down to Boston and I go on the street with a microphone like I'm a talk show host, and I say, "Hey, person on the street, what does an MD do, right? What does a physician do?" And I think most of the answers I would get back would be clinical, right? Everybody thinks the clinical. They see a patient, they produce a bill, they do surgery, they prescribe a medication, whatever it is that they are used to thinking in a patient-facing, environment. And, when you talk about technologies, we have tons of systems that help with this work, right? We have scheduling systems and pharma systems and electronic health record systems and all sorts of systems being built by large medical companies that are on the S&P 500, right? So we think of that when we think of an MD's employment, we think of them doing that work. But there's also lesser known components of a provider's time, or I should say lesser known by the person who would be asked that question on the street. And we often refer to that as the non-clinical protected time, meaning it's work that an MD does that is really non-clinical time. So let me give you a couple of examples of that. I'm going to give you some really broad categories. One of them would be like administration and supervision. So this would be time that an MD spends to run the health system. So think of someone who is in charge of a department with other physicians in it, right? Administration and supervision. Often it'd be a medical director or a section chief, probably would be terms that you hear in the healthcare system. There's also would be external contracts. Sometimes we refer to these as black box hospital contracts, meaning they're a contract with another hospital or a local business or a private party that really isn't part of the health system. So I'll give you an example of that. If a nursing home, a local nursing home, needs a medical director at their nursing home, right, they would contract a portion of a physician or a physician from the health system to be able to do that work. Also, obviously, we know teaching of undergraduates, right, the next generation of MDs that are coming up through, GME program directorships, and GME would stand for graduate medical education. So these are your residents and fellows, right? The doctor who is helping those residents and fellows learn their craft, right? Learn their practice. We have grants and research. Obviously, the National Institute of Health, having just gone through the COVID or being in the COVID pandemic, we would know that a lot of research took place in that. But there's a lot of other research that goes on, maybe to see smoking or obesity or whatever it is that it's going to be studied by MDs. So they do grants and research. They also do something called cost shares. Cost shares really are in the grants and research space, but it's like a donation of time. And so it's almost like the institution is doing it pro bono and saying, hey, we want to be able to study this. There's obviously discretionary funds and then also donor funds. So that would be someone wants to, whether it's a donor organization says, hey, I want to support cancer research. How do I do that? So they're able to, be able to support that. So those are roles that, again, are really non-clinical time. So when we first started provider services, the issue that we are trying to solve is how do we track this non-clinical protected time? And what I mean by that is when prior to provider services, historically speaking, These things were tracked all over the place. Various different departments tracked them. Everybody tracked them differently, mostly in Excel. And as I would say, and those probably who are also here on the technology side would say, Excel is a wonderful tool, but it's probably not the best tool for reporting. It's more of a calculator per se. So we had all these Excel spreadsheets, all this stuff all over the place, and nothing was clear and transparent. So what we ended up doing was coming up with a mission statement for our provider services group. Let me take a quick second to be able to read that mission statement. It said, provider services is a centralized business intelligence repository of top drawer provider analytics. Provider services tracks and reports provider non-clinical protected time in a concierge manner to operational leadership, individual providers, resulting in a fully accurate clinical FTE, or what you would be able to think of as the clinical schedule. So essentially what we were going to say with that mission statement is we have physicians who are, let's just say they're a 40-hour-a-week, I'm oversimplifying, but let's just say they're a 40-hour-a-week physician, and they're spending what portion of their time doing this non-clinical time, which then also reduces down to what is their actual clinical time. There's a couple sub-points on that. We wanted to be able to track it at the protected time at the individual level to have a single source of truth for the provider. Again, go back to my scenario of pre-provider services. This data was all over the place. Maybe even the home department didn't have it. I'll give you for instance, somebody starts as a GME program director, meaning they're going to be in charge of a graduate medical education program. And the home department wasn't exactly sure when it was going to start or when it's going to end, when the students are going to come in, when the students are going to go out. So they didn't have a way to go back and be able to see that in the dashboard. They had to go back to the GME office with emails or spreadsheets or whatever and say, hey, when's the start date? When's the end date? The same with grants, all these other types of things. They couldn't see clearly at one spot. There was a lot of emails, a lot of Excel spreadsheets. We also wanted to be able to report this information out in what we considered real time, meaning within a week or two of the activity taking place. So when you're dealing with Excel spreadsheets, and we know all know this from the technology standpoint, there's multiple versions out there. It's hard to track them. You have to ask somebody for their spreadsheet. They send it to you. They send it to you once, and then a week later, if you think the information's changed, maybe you have to go to it again or find it in a folder or whatever. It's just not a very good way to be able to get the information. And so we wanted to be able to have it in a really timely manner. The third part was we wanted to be able to assist senior leadership and also people in clinical operations to be able to see the reports. So we wanted to be able to, one, track the data. We wanted to, two, to be able to have it clear and transparent. And three, we wanted it to be able to be reportable or very viewable, and for operations to be able to use. So back to the question, how exactly did provider services do this? Well, one, we had to first pull all the data into a single platform. Our first major system that we had to connect to in every instance was to the ERP system. Often the HR or the finance side, we had to get the information on the individual providers. This is where we get employee ID, home department, name, job distributions, or pay components, as some people call them, to be able to get the information on the provider. When we first did that, when the group first decided to do that, we actually pulled the data weekly. But what we found was there was enough changes from week to week that wasn't often enough. So we went almost the opposite extreme, and we ended up pulling that information from the ERP system. It ended up being like 6 or 8 times a day. Today, we settled pretty much on a 3 times a day sync. We found that once a week isn't often enough. Things change, so if you're only pulling information on a Monday and things changed on a Tuesday, you don't know it to the next Monday, and that's not good. We also knew that spending a lot of energy to pull it, 6, 7, 8 times a day wasn't worth it as well. So we ultimately have settled into a 3 times a day sync. So that's our first step, is we have to get major system data from somewhere from the ERP system. Second, we had to create a master library of all our non-clinical protected time. That was really a lot of work when you first do it, because you're going to all these different departments for all their different providers, all the different administrative departments, and you're saying, hey, I need to somehow come up with a master library of all my non-clinical protected time. And we put that in a list. Now we have a master library, as we call it, where we can see all these roles, right? You can now benchmark, you can compare, you can see what happens, you can see start and end dates. All of a sudden you have a valuable tool at one location called our master library versus a whole lot of spreadsheets across the organization. Third, we wanted to make sure the provider would be able to see this. So what we actually do at the end of every month is we send an email to all the providers and we ask them to view what we call a form and say, are these roles correct? So essentially the provider himself is ultimately choosing to, say, hey, these are the activities that you think I did, and yes, are these correct or not? We have a process in place where if the information is incorrect from the provider standpoint, we can go in and change and make edits. But again, we capture that information directly from the provider. We send them a budgeted email that says, here's what we think you did. They say yes, they sign it, very basic electronic signing, and we get it back. So now we have the information in a real-time data set at that point. That's really where the value becomes downstream, right? So once we collect all that data, and we're talking hundreds and sometimes thousands of providers here, then all of a sudden you can take that data set and you can use it. So again, to go over our major points that we had to do with provider services is, first we had to connect to our ERP system to get the information. Second thing we had to do was collect from all the various departments the non-clinical protected time and put it in what we call a master library. We use that master library a lot. We do analysis on it, but we also take that master library and the provider will see the list of the things that they were doing with their time. And then finally, we have a real-time data set. And when I say real time, the providers are able to see their information for about 7 days inside. So 7 days after the end of every month, we have this data set that now we can send bits and pieces to. For instance, if the GME, the Graduate Medical Education Office, says, hey, what was provider time just working for GME? We don't send them all the information. We simply slice and dice the GME time for them. The same with contracting for invoicing. So again, the physician who would go on a contract, we need to invoice that hospital or health system, whatever it is, to be able to say, hey, the physician came and we need to bill you for your time. We're not sending them the whole master data set. We're just sending them their slice. But again, that all drives from having one data set at one location versus spreadsheets all over the organization. So provider services, the value of provider services in a nutshell, in a sentence or two, would be essentially that we took non-standardized data points from all over a health system. We created a centralized source of truth that is clear, transparent, and timely. And we can use that data there for everything from business intelligence to actually creating invoices. The key takeaway really to provider services is that this is beneficial for the health system. It's beneficial to the providers. It's beneficial to the operational folks because they know what their providers are doing and when. And you know what? As with any health system, the most important part of this provider services is that it helps the patient. It's good for the patient because the providers then are able to provide the right care at the right time for them. And at the end of the day, it seems like we all become patients of a health system sooner or later at some point. So Paul, did that help a little bit? Can you hear me okay?
So a couple of quick questions I had. So first, I thought I probably should have pointed this out as part of the introduction, is that when I think of healthcare and the systems that we need for healthcare, I tend to divide them into two different parts, right? I like to think of, if I look at a healthcare organization as a whole, I think of systems on the clinical side that drive the clinical stuff, if you will, And then I think of, systems on the operations side that help keep the institution running, right? Or keep the lights on, so to speak, is the way I think about it, right? And so maybe it would help to point out that that what we're talking about when we talk about provider services and helping to protect these providers' time and the compliance that goes along with that. It's worth noting that that this falls more on the operations side, right?
Yeah, it is. I guess what I would say to that is when you think, if you would try to list out at a normal healthcare system across the United States, just take the average healthcare system. If you would look at their technology and say, how many different systems and software applications do they have on their server farm, right? The instances would be huge. And so the question comes down to is there's all these different software systems. Some of them do something that's very specific and don't impact a lot of providers. And some of them, like your ERP, impact all the providers. And so what you need to do is have a way to pull all that information together to one source where it's transparent. And again, I go back to, the history of, hey, how were we originally tracking this thing, right? We are tracking all these different components of physicians' time in Excel. You had multiple people running around to get this. Again, my example would be if I was sitting in a provider's home department and I wanted to know what day, let's just take a National Institute of Health research grant started, when it started and when it ended, I had to go to the grants department to ask that. I didn't have a way to find it for myself. And so when I'm doing that for multiple providers, then I'm doing it for all those non-clinical roles that I've listed. When does a contract start? When does a contract end? When does research start? When does the research end? You had to go into all these systems or to multiple people to be able to get it. And so the emails were just flying around, right? And we know how emails in Excel work, right? You send an email, and the person's going to respond to you quickly, but even quickly could be 24 hours. And in the meantime, you've picked up that task that you were trying to do of scheduling the provider for their clinic, and you put it down, and then you get the answer back, and you have to pick it up again. So being able to have something clear and transparent where you can see it, right? You can go and self-service this information in real time is extremely valuable.
Yeah, it's interesting, and one of the reasons that I was excited to have you come on and talk this week is because of your expertise more on the finance, HR, the operations side, and bringing sort of the business language of this problem, if you will, to the table. From a technical perspective, I might call what you just described interoperability, right? The interoperability between these systems. And, it's interesting because we've seen a surge in interoperability, given, what the world's been going through in the last year and a half. And I think one of the biggest reasons for this is a lot of these large healthcare systems store the most sensitive data about patients that's still being stored more or less on-prem or in private cloud, right, in systems like Epic and Cerner are a couple of the top platforms for this. And so when you start to enter into this world where now we need patients to be able to log into a patient portal and see their medical history or other parts of their personal information, well, all of a sudden this interoperability becomes even more critical, right? And so that might be on the clinical side, but then if we look on the operations side of healthcare, you have this same sort of need and explosion around interoperability, if you will. And so it's interesting, how that's happened and how that's the growth, of interoperability over the past month. Just two more quick questions. We've only got 6 minutes left here, but if you had to pick out what was the most difficult part of going through this process of where would you start with that? How would you describe that? Or what would be your answer? Sorry, I got distracted with the slide.
No, probably from the very beginning, it would be anytime you're trying to build a single source of truth, as we would call it, right? Or a master feed, right? Kind of have somewhere where we have all this data at the same point. It's actually compiling the data, right? The real need for something like provider services is that you're a centralized shop. And so getting to the point where you're a centralized shop probably is the biggest piece, because some of it is discovering what you don't know. right? That's the biggest piece. And when you're trying to first set up a centralized shop from a whole various decentralized, department, that's probably the biggest piece, is try to figure that. And again, you're talking health systems often that have this information. They have the information. The information is found by somebody somewhere knows this information. But how do you get it? It could be information held by a hospital in a different state, right? And you've never met that person over there. So how do you get it centralized? Once you get it centralized and they get used to going to a location for a source of truth to be able to self-service, then all of a sudden they see the value of it. The end user, right, sees the value of this and wants to help move that information forward. But it's the initial setup, right, is probably one of the biggest parts.
And now you're sort of speaking my language. Like, I understand, one version of the truth and the issues and in pooling together disparate, pools of data, right? So that you can make actionable insights. We talk about this a lot in technology. So again, it's really interesting to hear it, from a business perspective. So, sorry, go ahead.
Technology side as well, right? If it's not timely, it's not valuable, right? If you're telling, if I'm not able to get information, right, ahead of time or right on time to be able to make business decisions on it, it doesn't help me if I know 45 days later, right? I mean, it's kind of like the idea of, hey, I want to be able to, where's my Amazon package? I want to be able to see where it is today. I don't want to it's up on my doorstep, right? We live in that world where it's like, hey, give me this information now.
So if you had to wrap up by just maybe if you could pick out what the most important lesson learned was, maybe this would be a good way to wrap up. We're coming down the last 3 minutes here.
Yeah. So the most important lesson learned, I would say, was that clear communication drives good business, right? And so I'm going back kind of to being timely. So whether it's everything from like, hey, we now know how much a provider is spending on a contract within a couple days of the end of the month so we can bill faster. And when we bill faster, and when you're talking about contracts that adds up, when you add up all your contracts, could potentially add up in the millions of dollars, then, my finance mind says, oh, well, that really helps your days of cash on hand, right? And I know this isn't a finance group, this is a technology group, but just think about that for a second, right? Mm-hmm. If you have to wait, if the health system has to wait 45 days to gather this information to send whether it's a $300 bill, $3,000 bill, or $30,000 bill over to another organization, and then get, have net 30 to get it back, from the point of service to the point you send out the invoice to when you get the payment back can be like 60 or 90 days. If you can do that much faster, better for you, right? And so that would be, I would say, would be the clear takeaways, being able to have the information accurate and timely. Information the different business units can do with it what they wish.
Yeah, I love that. I really like the first sentence. That clear communication is key. It does seem like more and more this is paramount. And to your second point, you're right. I was actually astounded when I first learned about this issue. It was several years ago, but this idea of these larger healthcare systems. That this can add up to a lot of money. Like if you can have different groups that owe other groups a significant amount of money, and if that's just sort of sitting in somebody else's bank account, then that's lost potential, right? For and then again, I'm not a finance person; I'm a technical person. But from what I understand, there's real dollars that can be associated with that, right? For one, you don't have it as part of your operating budget; it's sitting in somebody else's account. Two, when the dollars are big enough, you're actually earning interest and stuff off of this, right? So there's this as well. So yeah, I was surprised to learn about this problem. So Brian, this has been amazing. Thank you so much for taking the time today. It would be great to have you on again. Maybe in the 2022, we're wrapping up this year now, but it would be great to follow up on some of the details of what you talked about today. Maybe we can drill down into some of the specific areas, and maybe do it once a quarter. Talk a little bit more about the operations side of healthcare, not just the clinical side, if you will. And for those, so again, thank you very much. And for those watching now, I think it's on the screen. If you could pull up the screen, we have our mailing list and our Discord server. Don't forget, the links are here. And we'll make the key thing is if you go to the Discord/healthcare, you can find all the information you need. Like, we're making a conservative effort to have all the links in there and all the PowerPoint slides and all the meeting announcements. And again, for those that have joined us in the past, one of the things that we like to do is start on time and end right on time and respect everybody's schedule. So it's 12:30. We're going to sign off now. Thank you, everybody, for being here today. Brian, thank you so much for the discussion. Cheers.